And again, I want to welcome everyone. My name is Robert McCarron. I met some of you earlier before the yoga session. I'm the Director of Education at the Susan Samueli Integrative Health Institute, also Professor of Psychiatry at UC Irvine. So again, I want to welcome all of you here, and glad that we're able to learn together and on how to prevent health conditions, behavioral health conditions, and how to recognize and prevent early and also address these conditions. So today I'm going to be talking a little bit about depression. Again, overview on prevention, but also how do we know if someone has a clear depressive episode, and how do we treat it? And so I'll kind of cover the basics, but really before I start, I think it's really important, let's see here, to know what all of you might want to know. So I have a bunch of slides here, but I am also interested in what you want to get out of the next 45 minutes or so. Feel free to chat or Q&A on things that you definitely want me to cover when it comes to depression. I'm happy to do that as we go along. In addition, as I mentioned earlier, we're also going to have an Ask the Experts session where we're able to do some Q&A. But certainly feel free to let me know during my talk if there's any questions, and I'm happy to address them as we go along. Today, over the next 45 minutes or so, we're going to be talking about depression. I was talking to a friend of mine. He said, "Robert, why do you talk about depression? It's so depressing." And I thought, yeah, it kind of is. But at the same time, it's not. It's not, because it's something that can be reversed. It's something that can be addressed. And there's nothing more special than seeing someone struggling with depression, struggling with profound sadness, and then starting to feel better, starting to see the lights go on. And so that's what we work for, certainly. We're going to be talking a little bit about bipolar depression. It looks very similar to that regular depression that so many folks have, and then prevention and also treatment. Now, a couple things to keep in mind. Here's the deal. Depression is very common. That's why I'm talking about it today. In women in particular, during an entire lifetime, about 20% of women will be struggling with depression. And it's a leading cause of disability among adults. It keeps people away from being productive at work and even with families at times. Unfortunately, the diagnosis is missed a bunch of times. It's not picked up. We'll talk about why that is in a bit. And even if you look at kids, there was a recent study out of UCLA that showed about half of kids between the ages of 13 and 18 suffer from some type of psychiatric condition, particularly during this pandemic, which has just made matters worse. In fact, in my own practice, I've seen many folks in their 20s and 30s, more so than usual, suffering from depression and anxiety. So here's the deal. It can be addressed, it can be treated, it can be prevented, and that's why we're here talking about it today. So a little bit of a background. It's important to point out, unfortunately, and because due to this conference and in other ways in Orange County, we want to change this fact that I'm going to tell you here in a second. About 60% of people suffering from depression or other common psychiatric disorders are just not getting treatment. They're at home struggling, suffering, not being able to sleep at night, and really struggling. So that's unfortunate, and that's something that we definitely want to change here in Orange County and beyond. About 40% are receiving care, but here's what I want you to know. We don't have a lot of psychiatrists. We don't have a lot of psychologists. The majority of mental health care delivery in this county, in this state, in this country is delivered by non-psychologists, non-psychiatrists. Most of this care is delivered in the primary care setting. It's important to know that, because we want you to communicate with your family medicine doc, your internal medicine doc, whoever your primary care provider is, and talk about depression and have those discussions, because about 40% of their day when they go to work is spent on working with people, with patients who are struggling with depression, with anxiety. So really want to keep in mind that depression is something that can be addressed, but if we don't address it, we kind of ignore it, we let it go, it can linger on. A typical episode for depression can last 18 to 24 months. It's a long time to suffer. If you don't address it, if it's not treated, it'll linger at least past 6 months. So Larissa's asking if I can speak on how the forms of social distancing during COVID have influenced rates of depression, and they have. I mean, I would say loneliness has been a catalyst for depression. Where people may not have had a clear depressive episode in the past, we're seeing more of that during COVID. No doubt about it. Um, and then Kristen has a great question. In addition to medication management and therapy, what are some of the most effective coping skills for depression? We're going to talk about that because it's important to note that treating depression with antidepressants can be very, very helpful. There's also other ways to deal with it, looking at nutrition, looking at exercise, looking at talk therapy, right? A lot of these things are very, very effective, either alone or in combination with antidepressant therapy. One thing you're going to hear me talk about multiple times throughout this presentation is to partner with your provider. What I usually tell patients that I'm working with is that they know their body, their emotions, their thoughts better than any doctor, any provider. And hopefully the provider, the doc, will understand the intricacies of medications and treatment probably better than most patients. That combination together is magical. But keep it in mind that partnering with the provider, instead of just saying, "Hey, I'm here to get better, and can you make me better?" I suppose can work on some occasion, but it's much more powerful if there's a partnership between the provider and you as well, the patient. So education is prevention. We're going to be taking a little bit of time talking about what major depressive disorder is. We're going to talk a little bit about how we train docs and providers, how we train them to look at depression, which questions they ask to figure out if someone might have depression or bipolar disorder. And we want to give that information to you. It's powerful information, so you have this, and you can use it for yourself, for your family, and for your friends. So I'm a visual learner. I like to look at figures and graphs to figure things out. So my hope is that this particular figure will be helpful for each of you. So a little background, this blue line right in the middle here, this blue line is labeled euthymia. That's a fancy word for feeling good. That's when someone feels good. They're not feeling sad, they're not feeling depressed, and they're not feeling the opposite of sad or depressed either. So this blue line is really where we want to be, right? This is kind of the magical sweet spot, if you will. So I want to point out a couple things. Below this line, right, is going to be depression. That's going to be when someone's kind of sad, they're really down. The further down they get on this curve means the more depressed they are. Now on the flip side, if someone is up higher than euthymia, right, then they could be having what's called a manic or hypomanic period. Hypomania is just a smaller version, a less significant version than mania. But basically, people can have these highs, right, where they have mania, in which case they would have what we call bipolar disorder. Now, most people with bipolar disorder do flip down again to depression. Most people with bipolar disorder tend to have depressive episodes more than the opposite of depression or mania. So I mention this to you because a lot of times patients can look really sad, really depressed, maybe suicidal. They're struggling, they're tearful. It's hard to get motivated to get to work and do things that they need to do. And we need to realize that it could be what we call major depression, major depressive disorder, but it could also be a part of bipolar disorder as well. I don't want to get too much into this, but it's something to kind of think about as we go along. Now, this is an interesting slide that I usually will present to primary care providers that we train out of University of California, Irvine, and sort of the nuts and bolts on questions that we might want to ask patients who are struggling with sadness or mood issues or anxiety. And so these are questions that we train primary care docs to ask on a daily basis with their patients. And I'm going to share them with you because these are questions you could kind of ask yourself, right, to kind of figure out how you're doing, but also you can keep these questions as a resource to ask loved ones, patients, family, and friends who might be struggling as well. Anxiety is very common, and again, this is the anxiety. The A in anxiety goes along with this mnemonic of AMPS, AMPS, and anxiety is very, very common. Anxiety can be something that can actually help us be effective and successful in what we want to do on a day-to-day basis. But if that anxiety level gets too high, it can be a problem. And I think many of us probably either have had anxiety where it's not, it's at a high level, or we know someone who has. So really being aware that anxiety can go along with depression. Those two can actually be married together. And so just asking, hey, you're asking yourself, your family member, your friends, is anxiety or nervousness a problem for you? When we talk about mood, we're trying to figure out if someone has a low mood. We want to think about depression, right? And the two questions that providers and docs are trained to ask when it comes to depression are the following. The first is pretty straightforward. Have you been feeling sad or depressed over the last 2 weeks or so? And the second is related to interest level and hobbies, for example. So asking a loved one, in this case, hey, what do you like to do for fun? And have you been doing those things over the last couple of weeks? Because if they haven't been doing things that they used to like to do, that could be because of a depressive episode that they're in. Now, we talked a little bit about mania earlier, and so remember, someone can be manic at some point in their life, and that mania, or that excessive level of energy and excitement and talkativeness, that's really excessive and out of the ordinary for a particular individual, can result in long periods of depression later in life. And so we look out for that as well. And these are two questions that we can ask to figure out if someone in the past has had that manic episode, right? And so, and we'll talk about mania and hypomania a little bit more in a second. Now, there's this thing called psychosis. Psychosis is found when people are really, really profoundly depressed, or when people might have schizophrenia. And there are other reasons for psychosis as well. But basically, a quick kind of thing to consider as to whether or not it may be a loved one it has psychosis. It could be asking about what we call hallucinations. So asking someone, hey, do you ever hear things or see things that other people don't hear or see? And then also sometimes when people have psychosis for whatever reason, they have a higher likelihood of being paranoid. And so sort of, asking the question, of a loved one or someone who you're concerned about, do you have thoughts that people are trying to get you, follow you, hurt you, or spy on you, is something that you can kind of ask. Now, unfortunately, in this country, substance misuse is a huge problem, and it's getting worse. In fact, it is certainly an endemic here in this country, and increasingly more of a pandemic throughout the world, particularly when it comes to fentanyl and other what we call pain medications called opioids. And this problem is getting worse. A number of accidental deaths due to fentanyl in particular is increasing significantly. So if you have a loved one, for example, who you notice is a change in mood, or more anxious, or maybe a more avoidant, you can ask, if they're using alcohol, you can ask if they're using, cocaine, heroin, acid, speed, ecstasy, marijuana, or even pills that are not prescribed. And asking these questions, could also be helpful. But these are questions that we ask on a regular basis, on a routine basis, when we see when providers see folks in clinic and they're concerned. So hopefully that's kind of a helpful overview for you. Now, so what is depression, right? What is major depressive disorder? And sometimes we hear of this as, quote, clinical depression. And basically, depression is when you have at least 2 weeks, usually more, of a depressed or sad mood, coupled with low level of interest, like we talked about a little bit earlier. Now, you can see here that there are other sort of things that we consider when we're deciding to diagnose depression. But I will say that this is another sort of memory exercise or mnemonic that we can use to look at what makes up major depressive disorder and what to look out for, not only maybe for yourself, again for loved ones, coworkers, etc. And so using this mnemonic SIG ECAPS, right, can be helpful. And let's just go through some of these things to consider when we're looking at what major depressive disorder is. So sleep. Sleep is frequently a mess when someone is going through depression. It can be too much sleep, or it can be too little sleep, or insomnia. Either way, when sleep is a mess, folks are struggling, and the rest of their life is usually a mess as well. So asking about too much sleep, too little sleep it can be important. We talked about gauging someone's level of interest in activities that they used to like to enjoy is important. A lot of times patients will feel guilty when they're depressed, not always, but that can happen. And then very frequently we see a low level of motivation, a low level of energy as well. So you'll hear, people who are struggling with depression say, I just feel like I don't want to get out of bed. I'm just not feeling well. I don't have any motivation. Concentration is also adversely affected. And so the ability to focus is often hindered. Now, we see this sometimes with people who might be diagnosed with ADHD, and it's really the problem really is depression, right? The ability to focus or remember things. And so frequently what we'll see is, addressing the depression can help with what may have been considered ADHD. So that's something to consider as well. Appetite can be affected. The appetite can go down or can go up. And then something that we call psychomotor retardation or agitation. People with depression characteristically just move slower. They'll think slower. And then lastly, in this mnemonic SIGI CAPS is suicide. People may have thoughts of wanting to end their life. And this is something that we certainly, unfortunately, have seen a spike in the last 20 years. There's been about a 30% increase in suicides in this country in all age groups over the age of 8. So again, when someone's depressed, it's important to get them to connected to see a provider, and to do that urgently if they're having thoughts of wanting to hurt themselves or kill themselves. One of the questions that Jose is bringing up is, protein powder is okay to increase protein intake? Well, this is a question that we're going to have to ask Sherry a little bit later, but not related to depression. But we will definitely, Jose, address that in a little bit. Okay, so let me move on to sort of defining what mania is, right? And that the one way to look at this is it's the opposite of depression. Folks who are manic will, at some point in their life, feel the complete opposite of depression. So, abnormally happy, abnormally expansive, um, irritable, right? And during these times, they're very likely to do things that they wouldn't normally do. Examples would be shopping excessively, buying tons of stuff, and maxing out credit cards when they've never done that before. Another example would be really overproductive to the point where they're not able to produce successfully. They want to be overproductive. They're not sleeping at all. They're staying up for days and days, but their thinking is sort of chaotic and disjointed. And so we look for expansive, irritable, and/or elevated behavior in those who have a discrete manic episode. Now, when someone has a manic episode, it can last, about usually a couple weeks, maybe a week, if not treated. A lot of these folks can also end up being hospitalized. This is kind of a more detailed overview on what we see with manic episodes. Again, heightened level of sort of grandiosity. These folks don't need to sleep when they're struggling with mania. Much more talkative, to the point where it's hard to interrupt them when they're talking. Quick, rapid, racing thoughts, and oftentimes they're very distractible. Excessive involvement in pleasurable activities that go well beyond what their normal level is, and again, suffering from a what we call a social or occupational dysfunction. and not really thriving at home or at work. So I want to talk a little bit about medications. Now, I bring this up because um, it's frequent where we'll frequently see folks come in and saying, "Hey, I'm feeling sad. I'm feeling down. I think I have depression. Can I have an antidepressant?" And certainly, there's opportunities for using antidepressant. Antidepressants can be effective in the treatment of major depressive disorder, but it's always important to not, I would say, exclusively focus on a pill or on a medication, but instead to look at the deeper root, right? What's causing this depression? What's bringing it forward? What are the roots, if you will, of this depression? And so it's important to look at this and consider other types of therapy in addition to, or potentially in lieu of, an antidepressant. So making sure the whole person is well, right? And so looking at exercise, making sure nutrition is considered, looking at food as medicine, making sure that we are mindful of what we're doing throughout the day, and that our brain is not just kind of all over the place. And we'll talk about mindfulness here shortly. So these are some things to consider. Now, with all that being said, some of the most frequent questions that I do get regarding the treatment of depression include medications. So, what I've done here on this chart is I've covered four main types, or what we call classes, of medications, and listed some of the more common side effects over here. And so I want to talk about the most commonly prescribed group or class of antidepressants. And I would say probably one of the very top groups of medications prescribed in this country. And that would include the serotonin specific reuptake inhibitors, or what you may be familiar with in terms of what we call them as SSRIs. And so these medications include some names you may be familiar with: Prozac, Zoloft, for example, Lexapro, Celexa, and others. These medications are pretty safe on the heart, the kidney, the liver, and the brain. They can be used along with talk therapy, which we'll talk about in a second. And they're pretty safe medications when it comes to weight gain or sedation or heart issues, etc. One thing I will bring up, though, is that there is an increased likelihood of related sexual dysfunction, which means these medications may sometimes decrease the desire to have sex, also may decrease the ability to have sex, may alter someone's ability to perform sexually relative to their baseline before they were on these types of antidepressants. Now, I want to point out that if the side effect does come up, if this does happen, removal of the medication along with the provider who's working with you could or will actually remove that side effect. So these side effects are completely contingent on use of the medication. We'll talk more about some of these medications here in a second. And then there's the SNRIs, the serotonin norepinephrine reuptake inhibitors. Now, the reason I'm talking about these medications is because increasing or optimizing serotonin or norepinephrine in certain parts of the brain can be very helpful for the treatment of depression. Now, SNRIs are frequently used not only for depression, but also for pain. So many of these medications are also used for pain, particularly what we call neuropathic pain, oftentimes diabetic related pain. And they have the same side effect profile, pretty safe. And then again, some people may have some of these sexual dysfunction related side effects or decreased libido. Mirtazapine and Remeron is a medication that's very different in terms of how it works. It can cause folks to be a little sleepy. It can cause a little sedation, but this is a medication that can be very effective for the treatment of depression or anxiety. And then I want to briefly talk about bupropion, or Wellbutrin has another name, a third name, which is Zyban. So Zyban is a medication used sometimes to decrease cravings for cigarettes. And we want to make sure not to use Zyban in addition to Wellbutrin. or bupropion, right? I have seen some patients say, hey, I'm taking this medication to stop smoking, but I'm also taking the same medication at a higher dose to help with my depression. So you want to be careful of that. High doses of bupropion or this particular medication in those who have a history of seizures is something to look out for. So if someone has a history of seizures, for example, or eating disorders, you'd want to stay away from this medication unless talking to a doc about it. So these are some of the most commonly prescribed antidepressants. I'm not going to go through all of them, and I'm happy to address specific questions later this morning. But sertraline or Zoloft is a medication that's been around a long time. We use it pretty frequently for the treatment of depression and anxiety. I think Dr. Hahn will be talking about this medication a little bit later as well. Paroxetine or Paxil is a medication that we're using less and less because there's more likelihood for side effects like sleepiness, increased appetite, and also potential for malformation of the fetus during pregnancy in women. So try and stay away from using this during childbearing aged women. Prozac is one of the older medications, came out in the 1980s. We have the most history with this medication, know most about it. Safe medication, and then Lexapro and Celexa. These are two medications that look very similar to each other in terms of how they're arranged, and they're very effective for the treatment of depression and also anxiety. So just a quick example of these serotonin norepinephrine reuptake inhibitors: venlafaxine or Effexor, duloxetine or Cymbalta. Again, these are medications that we use pretty frequently for the treatment of depression, anxiety, but also chronic pain. So you may see it used in that area as well. These medications, particularly venlafaxine, can potentially increase blood pressure. So we want to be careful if someone has a history of high blood pressure to maybe not use these medications as a starting point. Okay. And again, if there are any questions about these particular medications, certainly let me know. I'm happy to answer any of these questions. Okay. And then also asking about what supplements or foods might be helpful with depression or bipolar disorder and medications. So there are a lot of different supplements that we can try. The most, I would say, tried and tested would be St. John's wort for the treatment of depression. At even low doses can be very helpful, and the idea is that it stimulates the activity of serotonin in certain parts of the brain. We're also going to talk more about specific supplements that can be used for the treatment of depression here in a little bit. Okay. Is there a list of the name of medications alongside the type of drug and thanks for the point on Wellbutrin? So yeah, it's interesting. Each medication has two names. It's which is a little confusing. So for example, bupropion and Wellbutrin are the same medication. So it could be a little different. But to be clear, this medication bupropion also has a third name, Zyban, which we frequently use to help with decreasing the desire to smoke cigarettes. So I don't want to go too far into the next couple of slides, other than to say, if someone has bipolar disorder, the treatment from a medication standpoint and from a supplement standpoint gets a little more complicated, and that's when talking to your psychiatrist is going to be really important. If someone has a background or history of being in the hospital because of bipolar disorder, in particular, or thoughts of suicide related to bipolar disorder or depression, seeing a psychiatrist on a regular basis indefinitely is advisable, and to make sure that that if symptoms do get worse in the future, that we are able to catch it early and work together to decrease those symptoms. There are other medications that we would want to consider here, and these are just a few examples. Some of you may have heard of medications, lithium, and also Depakote or divalproex. These medications are used as, quote, mood stabilizers. and they are used to help patients not go back into that manic phase. So psychiatrists and patients together can talk about using these medications in addition to, or again, even potentially separately or in lieu of antidepressants. So these are some medications to consider. Again, these medications generally, would be prescribed by a psychiatrist as well. Okay. So what I really wanted to spend some time on here is talking about non-medication ways to treat depression, and really effective ways to treat depression. Because again, I know a lot of times we're thinking, hey, we want a pill, we want a medication to take away the sadness or the depression, but there are also ways that are going to be effective and sustainable in terms of treating depression. Ideally, you want to look for a type of talk therapy that can teach you tools on how to recognize and address depression in the future. And so, what I'm going to be talking about over the next few minutes is something we call cognitive behavioral therapy, or CBT. And I'll walk through sort of the premise behind CBT. And again, this can be used in mild or moderate cases of depression without an antidepressant. If someone has severe depression, the recommendation would be using talk therapy or CBT with an antidepressant, as well as with other preventive measures like we talked about, including making sure that exercise and nutrition are considered, as well as we'll learn in a few minutes, learning a form of mindfulness techniques that can be very helpful when addressing depression. So here's the background on cognitive behavioral therapy. So the brain is a very I would say tricky organ, in that the reality is, in the world of behavioral health, in the world of psychiatry, we don't really know what causes depression. We don't really know exactly what causes bipolar disorder or schizophrenia or PTSD or autism. There are a lot of unknowns in psychiatry. There are more unknowns than knowns. And I think that's why it's important to look at the whole person, not just here's a medication or what is your mood, right? But to look at the entire person and how they're functioning at work and at home and socially, etc. But it is a bit of a bummer, and I'll have to say the reality is we don't really know what causes a lot of these psychiatric conditions. Now, because we don't know what causes them, we're stuck sometimes because we may not have the best treatments, right? We don't have a cure for schizophrenia. We don't have a cure for bipolar disorder. Many patients who have major depressive disorder can and oftentimes will have another episode in the future unless we're able to prevent it and use a whole person care approach to treatment. So, with all that being said, we know there's something happening in the brain, right? We know there's a quote chemical imbalance, probably related to serotonin, dopamine, norepinephrine, these neurochemicals in the brain. And we know that because of that, folks will feel sad. They may feel anxious. They're going to feel down. They're going to be emotionally distraught. We know that. We know that there's connection. It's intuitive, right? But what we often forget or may not know is that there is a connector piece between what's going on in the brain and how someone is actually feeling emotionally. And that connector piece is what someone is thinking, right? And so let me explain this a little more clearly. A feeling or an emotion is usually a one-word descriptor, right? So examples would be anxious, mad, sad, unhappy, jealous, etc. And so a feeling can be described really with one word. And it's a feeling is something that you don't have to contemplate. It's just there. You get up in the morning and you have it. And that is what usually brings folks to see their provider. It's that feeling that they're having, the feeling of being, again, emotionally upset. And so this feeling part or emotion part is the big problem, right? What's the hidden piece here is what someone is thinking, right? And what someone is thinking is different than what someone is feeling. So what someone is thinking is more than one word. It's usually 4, 5, 6 words. And that thought is usually connected to a feeling. And we'll talk about some specifics here in a second. The whole idea behind cognitive behavioral therapy is to recognize sort of this this connection, right, between the brain thinking and then feeling. And oftentimes when folks are struggling with depression or anxiety, for example, they're going to have sort of wacky thinking that's not accurate, right? And so that can be damaging, and that results in these feelings or emotions that are hugely problematic. And we're going to be talking about some of these thoughts that are dysfunctional, in that they're inaccurate, right? So when we think about dysfunctional thinking, we're thinking about thinking that's not accurate. It's not fully based in what's really happening. So unfortunately, what we see is when we do get depressed, when we do get anxious, we have these thoughts that are running through our head, and a lot of times we don't know they're there. They're just there. They're floating in our head, and a lot of times these thoughts are inaccurate, and those inaccurate thoughts are damaging and causing the problems with how we feel. So that's kind of an overview on cognitive behavioral therapy. The whole idea is to take this part out of the equation, the dysfunctional thinking, so the feelings improve. Okay, and so this is a widely used, widely studied approach to treating depression and anxiety. So let me give you some examples of what I'm talking about here. So an example of someone having an automatic dysfunctional thought that is not accurate, and this is a common one, is nobody likes me, right? Nobody likes me, or everybody hates me. And when you're listening to these thoughts, you want to listen to these words that are sort of dichotomous. They're all or none thinking type words. Nobody, always, never. Those types of words aligned with this type of thinking is usually not accurate. Now, these inaccurate thoughts again can lead to feelings of depression and anxiety. So what we try and do is teach folks how to recognize these dysfunctional thoughts, pick up on them, and say, "Hey, is this true?" Right? And if it's not true, then reconstruct the thought, reconstruct it so it is true. And these are some examples of what I'm talking about here. So a very common dysfunctional thought is nobody likes me. One way to reconstruct this thought after learning or understanding that it's a dysfunctional, inaccurate thought is to change the thought to say that can't be true because my wife and kids love me, right? So then it's not so bad. It's not nobody likes me, right? Another example that we hear a lot is I'm a failure to everything I do. Another way to look at this thought or reconstruct it might be to say maybe I'm not good in this one area, but I'm really good in these other two areas. Again, you're taking away the catastrophizing, the all or none sort of approach to these thoughts. A third example: I will never amount to anything. This is commonly seen in folks who are struggling with depression in particular. And one way to deal with this is to reconstruct this thought, right? Make that thought into a more accurate thought. In this case, I already have a good job and I might be getting a promotion next year. Right? So recognizing that maybe you're not really good at some things, but you're really good at other things. I will never feel normal again. This thought is commonly encountered in those particularly who are struggling with pain, chronic pain. One way to reconstruct this thought is depression can get better with medication, and talk therapy and whole person care. That's one way to look at this and to reconstruct that thought. Reconstructing these thoughts lead to improved emotion, decreased depression, decreased anxiety, and that's what we're shooting for. The last example is I've always been depressed, right? Always. Now, they may feel that way for people who are struggling with depression for the last 2 years, right? But if you really look at it carefully and you look at the accuracy of this thought, one way to reconstruct it is that's not true. I was very happy when I got married and graduated from college. Right now, I'm struggling with depression. So again, this is a very effective way to deal with depression, to deal with anxiety using cognitive behavioral therapy. The one quick way to look at this is, and will tell patients to use the 3 R's when considering cognitive behavioral therapy. Most of this therapy is not done in the therapist's office. Most of this therapy is actually done at home, using these types of thought records, right? Where you're actually writing out your thought and then you're writing out the reconstructed thought. And it can be very, very effective. So what I tell folks who are struggling with depression or anxiety is first to learn how to recognize these automatic, inaccurate, dysfunctional thoughts, right? To pick up on them. A lot of times they're hidden and they're just floating around as thoughts all day long. The second R is to reconstruct the thoughts that are inaccurate, reconstruct them so they are more accurate. And the third thing is equally important, and that's to repeat, to continue to do this. And this is a lifelong skill that can be very, very effective for the treatment of depression in particular. As a resource, I do recommend the book Feeling Good by David Burns. And it's kind of a long book. It's a paperback bestseller. I recommend just reading the first 80 pages actually, and just as an introduction to cognitive behavioral therapy. If you're interested in learning more about it, and if you are interested in learning more about it, I would bring it to your provider and ask if you could get more resources or even potentially start using talk therapy. Again, very, very effective, and this is a tool that you can use for the rest of your life. So very, very effective. I do want to answer a couple questions here. One of the questions is, does Effexor cause heart palpitations? The answer to that question is not normally. It can, though, in some cases, because it does increase norepinephrine a bit. If it does cause heart palpitations, it might do so in the very beginning for the first 2 or 3 days. If you are taking the medication and you notice heart palpitations, definitely contact your doctor right away. Not normally a side effect we see. Another question here is, what has UCI Department of Health done for postpartum depression? And getting more information on this. So, yeah, and Shannon, thanks for your question here. We do have we do have at the University of California Irvine, the Department of Psychiatry does work with OB/GYN in screening for depression. There are different screening tools. There are 2 different screening tools for postpartum depression. Postpartum depression is common. And so if you or anyone that you know is struggling with postpartum depression, I definitely would touch base with your primary care provider. I will say that OB/GYN docs and primary care providers are on the front lines when it comes to postpartum depression. If the postpartum depression is really severe, then referring to a psychiatrist is going to be important. But thank you for your question. I'll take one more question here, and then keep in mind we do have an Ask the Experts Q&A session between 11:15 and 12:15, so definitely look forward to more questions there. Best antidepressant for an 89-year-old mother. Wow. Here's the answer. The answer is there isn't one that's probably best. However, that being said, if you had to choose one, I would say a medication that started at a low dose and going up slowly in terms of dosage as needed, right? So not starting at the normal dose, starting at maybe half the starting dose. There are 3 antidepressants that I would recommend for those who are on a lot of different medications, like diabetes medications, hypertension medications, or et cetera. Zoloft or sertraline is a medication that has decreased risk for side effects with other medications. And then also Lexapro is a medication that can also be used for those who are on a lot of different medications. So I hope that answered your question as well. But also making sure the sleep is regulated. A lot of folks who are older struggle with insomnia, for example, sleep apnea that results in insomnia. So make sure that we're looking at nutrition. Make sure we're looking at sleep patterns, and checking with your doctor is going to be important. I want to thank all of you for taking time to participate in this discussion on depression and also join us so far this morning. We have a great morning here going forward as well. Dr. Han's going to be talking about anxiety. We're going to be having an introduction to mindfulness as well, and then a Q&A session with several of our experts on mental health and integrative mental health care. So please stay with us here. We are taking a brief break from 10 a.m. to about 10:15. So join us back at 10:15.